Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Health Leader Forge is a production of the University of New Hampshire's College of Health and Human Services. Today's guest is Colonel David Bitterman, Chief Operating Officer of the U.S. Army's Southern Regional Medical Command. The Southern Regional Medical Command is the Army's largest regional medical command and consists of 15 Army medical treatment facilities located in the southeast quadrant of the continental United States, from Texas to Georgia and north to Oklahoma through Tennessee. The command provides comprehensive health care services for over 490,000 beneficiaries with an operating budget of over $1.4 billion and has more than 18,000 employees. Colonel Bitterman holds a Master's in Health Administration from Baylor University and a Master's of Strategic Studies from the Army War College. He is also a Fellow of the American College of Healthcare Executives and is a recipient of that organization's Career Achievement and Distinguished Service Awards. Welcome to the Forge, Colonel Bitterman.
Thanks.
So you were an Air Force brat, but you call California home. What made you decide to join the Army?
So my dad was a career Air Force non-commissioned officer, and the last 2 years of his life was my last 2 years of high school. And I was a pretty good student in high school, but I knew I wanted to go to college, and I knew I had to figure out a way to pay for it. So my interest in the Army was really as a vehicle to pay for my undergraduate education.
Okay.
And so I applied for an ROTC scholarship and won that scholarship, and there were 5 of us children in our family. I was the 4th, so I didn't know much about the Army. I kind of knew a little bit about the Air Force because I grew up in the Air Force up to about my elementary school age, so again, it was just mostly a vehicle to get my college education paid for.
So, and that's not uncommon. A lot of folks kind of start in that way.
Right.
And so you got your scholarship and you went to the University of California at Davis. And what did you major in?
Majored in biology, biological sciences.
Okay. And what were you thinking? Were you thinking about, a lot of guys, they wind up doing that, thinking medical school or something along those lines? Is that where you were going?
That's exactly what I was thinking of doing. So I had great plans on being a medical doctor. By that time, I had an older sister who was a nurse and loved the medical profession. It seemed like a great occupation. You're helping people, you're of service to people. And so that was my plan. Went to UC Davis, had a great pre-med program, really a great reputation. And so I figured I'd be in the Army for 4 or 5 years, take the MCAT, go right into med school, and life would be perfect after that, right?
Okay, all right. So you did ultimately take an active duty commission.
I did.
And you became a Medical Service Corps officer.
Yes.
And what is that?
So Medical Service Corps is one of the 6 commissioned corps in the Army Medical Department. There are 2 major subdivisions of the Medical Service Corps. There's the administrative series, which I'm one of those occupational specialties, and then there's the clinical subdivision. And the clinical subdivision is much smaller, and it includes things like audiologists and clinical psychologists and social workers and podiatrists. Now, all of the administrative areas are all of the non-clinical parts of the delivery of health care that exist either in the military or in the civilian sector. So when I came in the military, I was what they call a 70 Bravo, which is a generic field medical assistant. And as staff officer, I was in charge of putting together, running all the logistics, the personnel, the training, the operations for a combat medical unit. From the smallest, most basic size of 20 men in supporting an infantry battalion up to a mobile Army surgical hospital, MASH hospital.
So, but this in your early, in your early phase. So you came in, you became a medical service, a 70 Bravo, a
Yes.
general kind of field medical assistant is what we call it.
That's correct.
And you started in infantry, supporting the infantry.
I was in a 660-man infantry battalion,
Okay.
and I was in charge of 26 medics. So we provided all the medical care, the initial medical care, both in a deployed environment and in garrison while we were at home training for Army stuff. You know.
How did you feel coming in? You know, straight out of being a biology major at UC Davis, and the if I remember correctly, the drum major of the UC Davis marching band. Was that right?
Well, almost. You almost got it right, Mark. I was the first. I was actually drum major of my high school.
Oh, high school. Okay.
Marching band the last 2 years.
Okay.
I was in the Cal Aggie marching band though.
All right.
First 2 years. Played the mellophone poorly, but I did play.
So preparation to playing the mellophone and
Yeah.
ROTC.
Yeah.
How did that prepare you for this first job as a medical platoon leader in the infantry?
So the ROTC programs at most major universities across the nation give commissioned officers a good grounding in the basics of military history and doctrine and what it's like to be a small unit leader. But it really doesn't prepare you for the challenges of leading a team of, in my case, 26 men. Yeah. You go through a short course. I went through a short course here called the Officer Basic Course at Fort Sam Houston, Texas, in San Antonio, which was about 16 weeks long. And then I went to Fort Benning, Georgia, and learned how to jump out of perfectly good airplanes, as they say, with a parachute on my back. And then I went to my unit. And you are really a rookie when you arrive at your unit, and if you're a smart second lieutenant, which is the lowest, which is the grade you come in at, you'll listen to the more experienced non-commissioned officers who you outrank, but who are far more experienced at than are at delivering health care in that setting.
So who did you? Since you're still here and seem to have been fairly successful, I imagine you did actually listen to some of these gentlemen.
I did.
Yeah. So tell me about that. Who did you find that kind of influenced you during that period?
My first, we are an Army that was changing at the time.
Okay.
I walked into my med platoon, what they called a battalion aid station. I was met by my platoon sergeant, who had a cup of coffee in one hand and a lit cigarette in the other. And
this is the medical station.
This is the battalion aid station. And so, as I said, we were in an Army in transition.
Yeah.
And so, but outward appearances aside, this was a very seasoned Vietnam vet who knew exactly how to doctrinally support this large light infantry battalion.
Yeah.
And so he influenced me a great deal. I had a good cadre of about 6 non-commissioned officers in that group that really taught me how to employ and use a medical platoon in support of that battalion. It was really a phenomenal learning lab, really, and really kind of set the foundation for my future, I think.
Did you find a mentor at that time? Did somebody reach out to you at all? Above, so you've been talking about you learned a lot from the people who you were supervising.
Right.
Did somebody reach out for you either parallel at the peer level or above?
So I had, I don't think my experience was much different from most other second lieutenants. The battalion commander was a Vietnam veteran at the time. He was probably in his mid-40s. To me at the time, he appeared older than dirt, you know, and,
Right,
and
right.
incredibly wise, and
Yeah.
and knew exactly what. I got a lot of mentorship from him and
Yeah.
from the Battalion XO, who was his second in command, who were just normal guys
Yeah.
who were just trying to achieve our Army's mission at the time. Yeah. And then later on, as I progressed in my career, I ran into more and more mentors who really took great effort to kind of forming the way I thought and the way I acted, and really served as great examples for how I did the same thing later on in my career.
Okay. Can you give me an example of something you learned early on in this kind of initial phase, your kind of first several years in the Army, maybe not that job necessarily, but in terms of leadership or mentorship?
You learn things, good things and bad things, from watching people, I think. And I learned early on in my career that maintaining an even temperament, it sounds very simple, but maintaining an even temperament and not flying off the handle was a pretty valuable life skill to have. And I remember specifically, as I was a mid-grade officer, been in probably about, at this point, about 10 years or so. And I thought it would be a great leadership, situational leadership. You adapt how you treat people based on your specific environment and what's present. And at one point, I thought, and I very specifically remember this, that it would be a good technique to be very directive and very assertive, and in one particular incident. And this captain, who was the recipient of my very directive and very assertive situational leadership style at the time, came back to me about 4 hours later, and with great personal courage sat down with me and told me how that was really not effective. And boy, talk about an important life lesson. I took that and I did something with it, and I've been very careful not to react emotionally. Reacting emotionally is the easy thing to do.
Right.
Frankly, you need to, as a leader, you need to control your body language, your temperament, process what's going on around you, and then react maturely and logically to your situation.
So you spent kind of most of your early years in field units.
Yes.
Is that right? And so at what point did you kind of say, I like this Army thing, I kind of like being a medical service corps officer, I might let that whole medical school thing go? What kind of drove that decision?
So I was in Korea. I was a company commander of a MASH hospital, and I was busy studying for my MCAT. And this is at the very, this is at the time when we were at the cusp of, you started to see personal computers on desks and stuff. So I had stacks of 3x5 cards. We hadn't progressed to the point where we were doing online studying, and I remember having these massive stacks of 3x5 cards and just going through the repetitive memory and realizing that what I was learning, what I was trying to remember, what I was preparing myself for, was really something I didn't want to do for the rest of my life. I really believed that I was good at, and I really enjoyed small unit leadership. I enjoyed influencing others. I enjoyed leading organizations. And I looked at what some of our providers, physicians, were doing in this hospital, and I realized that some of them had probably committed to their occupation for the wrong reasons. They were chasing the prestige, the paycheck, what comes with being a physician, a doctor in our society. Mm-hmm. And I realized that wasn't, to me, as important as achieving my life goal. At the time, I didn't know what my life goal was, but I got there eventually.
Oh,
So,
interesting. Okay,
yeah.
so we can come back to that in a minute.
Okay, we
All right.
will.
Good.
Yeah, we should.
Good. Okay, so you're in Korea. At
Yeah.
what point did you? So you made at some point you made a transition to
Yes.
working in fixed facilities, as we call
Yes.
them. So what was that? How did that come
So
about?
the very next assignment, I was in Washington, D.C., and I was assigned to I guess what you would call our corporate headquarters,
Okay.
which is at the Office of the Surgeon General. It's where policy is made. It's where strategy is developed. And I worked for a guy named Major David Rubenstein. And I was a captain at the time. We shared a small office, and he was probably my first really effective mentor. And he had just recently gotten his master's in health administration through the Baylor University, and he talked to me about setting career goals and developing a plan to achieve those goals, and what we now know in the Army as a career map. And helped me develop that career map. And so that really set the stage for me to, okay, in 2 years from now, and this was back in 1991, 2 years from now, I'm going to enter a Master's in Health Administration program, matriculate through that program, and start being a healthcare administrator in the Army, with the goal of down the road leading a hospital in the Army or in the civilian sector.
Okay. So that's Major Rubenstein, later
Major General
Rubenstein. Okay.
Yeah.
So he had a pretty good plan going for himself as well.
He
right?
did, yeah.
Okay. So you went to Army Baylor?
I did. I entered Army Baylor program, which is a collaboration. It's a cooperative program between Baylor University and the Academy of Health Sciences down at Fort Sam Houston. Curriculum, all the professors are accredited by Baylor University. It's a great program. It's been in existence since, I believe, 52, 53. And in fact, we recently got word that U.S. News and World Report is now the 7th ranked MHA program in the nation, which we're all pretty proud of.
Yeah.
At the time, the first year, the didactic year, was a 60 semester hours crammed into 1 year.
Yeah. Intense.
It was pretty intense. There were 48 students in my course that started, 46 finished.
So you did 1 year of didactic, meaning you were in a classroom for a year.
And then 1 year, the second year is called an administrative residency. And so I went to Madigan Army Medical Center out at Fort Lewis, Washington for my admin residency, along with a Navy lieutenant. Okay. And we worked for the hospital. The administrator of the hospital was a gentleman named Thad Krupka, a superb mentor, and the whole purpose of this administrative residency was to teach the resident how healthcare is delivered at the user level. Okay. And so I rotated throughout that year, throughout the hospital and through other civilian organizations too. I spent. I went into the operating rooms. I spent time with the anesthesia providers. I spent time in the emergency department with the senior surgical resident on a payday weekend, on a Friday night. You know, I spent time with. I spent a week with a group health cooperative of Puget Sound, learning about managed care in one of our very first managed care organizations. Spent a week with the University of British Columbia, learning about Canadian healthcare and how it's delivered. Spent time at Harborview Hospital, a level 1 trauma center up in Seattle, learning about trauma care, and all of these experiences comprehensively came together and formed an experience base that I think a typical program you wouldn't have the opportunity to gain all these experiences and help you as you developed your own practice of your own style of practice later on as a healthcare administrator. Okay. Really a phenomenal program.
Yeah. Yeah. And so how did it change, or did it establish? I guess it's still early, relatively early in your career.
Yes.
How did it change or establish what you wanted to do, that career plan you had talked about?
So my career plan, my career map terminated in my becoming the lead healthcare administrator in a medical center, and later on I changed that career map to be a commander of one of those, the CEO of one of those organizations, and you don't leave an MHA program and say, well, tomorrow I'm going to be a CEO and I'm going to be a good CEO because I'm a good person, right? You have to have life experiences. You have to have the skills, knowledge, and attributes necessary to be successful as a CEO. And so my career map that I developed with my mentor, David Rubenstein, helped me chart a path to be that down the road CEO. My first step was to be a good administrator. And so right after I left the admin residency, I became the administrator for Department of Surgery there at Madigan Army Medical Center. We had 12 surgical teaching programs, about 600 people in the department, and I was responsible for all the administration, all the logistics, personnel actions, all the supplies, all the training, all the operations of that very large teaching department. And that was the first step. And so that later on, that and other assignments qualified me to be considered for selection to be a deputy commander for administration, first in a small clinic and then at progressively larger organizations after that.
So when you were at Madigan, this was the first time you had briefly been at the Surgeon General's office doing policy kind of stuff. Now you're at Madigan as the administrator for the department. How was leadership there, that role, different than what you had experienced before, particularly say in your experience with the line units, the infantry, and the MASHs and so forth? How was that different?
Much different. So in a leadership styles in a combat environment, in a what we call a MTO environment, an Army acronym, stands for Modified Table of Organization and Equipment. It's basically all the combat style units you see out in the Army, MTO units. Leadership styles there are very directive in nature, very mission oriented. You have a mission, you have your commander's intent, and there's not a lot of discussion about how to achieve something. You develop a plan, you train to that plan, and then you execute the plan. Things are much more fluid and much different in a fixed facility healthcare environment. The decisions are made in a much greater proportion through a consensus-driven effort. There are very many complex systems in healthcare, and they're all interrelated. The leadership or the governance structure of many organizations is more matrix-oriented, and so you work across the organization rather than up and down silos. Chains of command are sometimes confusing. Sometimes you work for multiple people at the same time to achieve certain objectives, and that managed chaos is actually very exciting. It's exciting to go to work in that kind of environment. You know what you're trying to do. You're trying to deliver world-class health care to our deserving patients, and given you have great flexibility to achieve that objective through working in that kind of environment. The typical department chief in an academic teaching hospital like that is very seasoned. They've been there for a long time, and you have to convince yourself and convince them that what you're doing is to their advantage and to their patients' advantage. Sometimes their motivations aren't the same as yours, and sometimes they're not patient-centered. Sometimes they're self-centered. And you got to work through those issues with those very senior leaders.
So you moved on. You did a number of things, and I'm going to skip forward in your career just a bit. to where you finally did have your first, what you referred to as a deputy commander for administration,
Right.
or what's sometimes kind of translated by Army folk like yourself to be a chief operating officer. And
Yes.
you had that was your first assignment in that position was at Raider Clinic.
That's correct.
In the DC area. Followed by a second DCA/chief operating officer role at Kimbrough Ambulatory Center, which is up in Maryland, right?
That's correct.
Both of these were outpatient treatment centers. What did you learn? Now you're in the role, the
Yes.
role that you'd kind of been looking at and saying, I want to be there. What did you learn from finally when you finally put on the hat and became the chief operating officer?
I think the very first thing I learned was I still needed to learn.
Yeah. Okay.
A practice I started when I took my first deputy commander for administration job was to sit down every week with my direct reports, and it was scheduled for an hour, and I always approached with them the first meeting. I always told them, look, this is our hour to get to brief each other on what we are doing. For you to bring me up to speed on the issues that are happening in your area, and for me to provide you the support I think you need to do your job. And so, at that point, I'd been in the Army for 14 years, and I had pretty good experiential base, but I had all these other departments that were now reporting to me that I had no experience with, like social work, like pharmacy, like patient administration. I really had no background in those areas, and so I really needed to learn from them, and they needed to be able to trust me, trust their leader, that I would have their that I would support them as they needed resources to do their job. So that was the first thing I learned. And then as I went to Kimbrough, so Kimbrough is a much bigger place.
Right.
They also did ambulatory surgery and also served as a higher headquarters for 4 other clinics that were out throughout Pennsylvania and Maryland. So you learn to operate over time and distance in that kind of environment too. And you learn to trust subordinate leaders, because what's the alternative? You can't be everywhere all the time. You must develop relationships long distance and trust that those subordinate leaders are going to do what you've asked them to do. So.
Okay, so that's a big transition from being able to walk in and look around at
That's right.
everything you're in charge of.
That's correct.
And I know, just from personal experience, having worked with you, you're big on that. You do make a habit of walking around, and talk a little bit about that. Why is that important?
I think it's vitally important. I think that first off, leaders need to know the environment where that their subordinates are working in. They need to know the challenges. They need to know what constraints they're operating under, and you don't get there by reading email, by sequestering yourself in your office.
Right.
And then your subordinates, they really need to know that they can trust your leaders. Okay, so when you go out and there's dozens of management books out there about managing by walking around and leadership rounds and whatever you call it. The reality is that the leaders need to get out so the subordinates can see and learn about their leader and learn that they can trust their leader to provide them the resources they need to get their job done. Healthcare delivery in our country is really it's a system of systems. There's a logistics system, there's a payment system, there's a hiring system in many cases, and how they interact with each other is really the science in healthcare administration.
Okay.
And you don't learn those things unless you get out and experience them.
Okay. Yeah. So you kind of bring up a point that I wanted to ask you a little later, but I'll pose it now, and that is your career spanned the adoption of electronic media. You were here. You were in probably before the existence of email as a management tool.
Yes.
Before social media, you've seen that kind of change the way we do business. Talk a little bit about the good and the bad. I mean, you've made a point that you don't manage by answering email,
yes.
but at the same time, it is a useful tool, right? I mean, or it can be
very useful.
So how have you seen kind of the pluses and minuses of electronic media, social media? What do you see that? How do you see that?
So it's about information sharing.
Okay.
Right. I believe that every person has a finite ability to deal with information effectively. I think you can process a lot of information ineffectively, but what do you do with the important bits of information that you really need to take action on? And so throughout my career, so I came in the Army when it was all paper,
yeah.
and it was all physical inboxes and reading one thing at a time and doing things very sequentially, yeah. and progressed to now I very routinely at my standing desk, because you gotta at my standing desk I get 200 emails a day and very few documents in my inbox, and yeah. things are done in a parallel manner, and they're done in a distributed way to multiple people. And you sometimes wonder in that kind of environment whether you are as effective as you can. And I get very worried, as you can be. I get very worried sometimes that our leaders today are treating things very superficially because they're being overloaded with information. There's too much information. And in fact, I've read a couple articles about that recently. Information deluge.
Okay.
What do you do with all of this? And it's a dilemma. It's a paradox. Back, I think 30 years ago, we weren't nearly as effective a healthcare system in our nation because we didn't have the information. Now we have it, and I think we're kind of hampered by all of the information that keeps coming at us. You can't process it all. And I'm not sure I answered your question, but that's the challenge I'm dealing with on a daily basis. Yeah. Parsing what's important from what's not important, and spending the time with what's important.
Well, so talking about what's important from Kimbrough, you were board selected to be the commander of the 212th Mobile Army Surgical Hospital, also known as a MASH, kind of like the TV show, right? And if I remember correctly, this was the last MASH in the Army?
That's correct.
Okay. And you were the last commander of the last MASH, is that right?
I was the last lieutenant colonel commander,
okay.
and then it transitioned to be a combat support hospital after that, so a different type of organization, yeah.
Okay. So what is a MASH? I mean, since most of us know MASH from the TV show,
yes.
What is a MASH actually? What is it? What's its mission? What is it? What was it supposed to do doctrinally? And what did you do as the 212th commander?
Sure. So a MASH hospital is a 100% deployable 36-bed surgical ICU. That's really it. It was designed doctrinally to follow very close behind expeditionary forces. That means a force that's moving into contact with the enemy, and then establish right up behind that force and provide very complex surgical care for the first month or so of combat. And that's exactly what the 212th did during the initial invasion into Iraq during 2003. I joined the unit shortly after the unit had been in combat for about 2 months. I joined the unit downrange, and then we.
So they were in Iraq.
They were in Iraq already.
Took command.
And they were the only hospital in Iraq for the first about 3 weeks of combat, and so they saw the preponderance of casualties. That there were long lines of evacuation and from where the invasion forces were farthest north into Iraq, and so that group of men and women really did some heroic things before I joined them.
Yeah.
A pretty incredible unit. The cool thing about the 212th MASH was it had such a great history. It was the most highly decorated combat hospital in the Army, and you took a lot of pride in that history. You took a lot of pride in the reliance you had on the men and women you worked with and the team you worked with. It truly was a team of teams, and it was probably one of the most enjoyable assignments I ever had. We weren't burdened with email. We weren't burdened with all the stuff we just talked about, the electronic media.
Yeah.
It was really very simple. You had a singular mission to deploy and support our combat forces, and it was very physically demanding. We traveled with 35 big 5-ton Army trucks, towing all of our equipment behind us in big trailers.
Yeah.
And when you got to your location, you had about 12 hours to set up this massive complex of tents and containers to be able to receive your first patients. And it was truly a fantastic group of people to work with. I was humbled every day going to work. So.
What was your role? You're an administrator, so you're not a surgeon. You're not treating the patients. So, what was your role as commander?
As commander, my role was to train the organization to their mission, and to provide them the resources they needed to get their job done.
Okay.
That's it in a nutshell. I felt sometimes my role was to buffer them from our higher headquarters, in a sense. I think in every organization, a good leader does that. You, as the leader, you develop the priorities for your unit, priorities in training, in manning, in resourcing, and there are distractors that get in the way, and you've got to guard against that. I think my role was also to influence those junior leaders and the soldiers of the MASH who were tired, who had families at home, and who were distracted sometimes, who needed to be encouraged, who needed to be reminded of their mission. That wasn't really that hard of a mission to do. Yeah. It's an incredibly dedicated group of men and women. Yeah, the leadership experience there at the MASH was truly a humbling one. Yeah.
Great. So from there, you came to, you took another Chief Operating Officer or DCA job back in D.C., and that was to be the DCA at DeWitt Army Community Hospital and the DeWitt Healthcare Network. What was kind of unique about DeWitt?
When I arrived at DeWitt in 2005, we had just, first off, the hospital is located in the national capital area. So the politics of operating in the national capital area is very unique. Okay. Secondly, a very large healthcare network, served about 70,000 or so patients in the Northern Virginia area, 5 distributed clinics and a community hospital with 43 beds. Yeah. The leadership team there was very unique.
Yes.
And so I worked for a Colonel Patricia Horho, who is now Lieutenant General Patricia Horho, our Surgeon General. And she had a unique approach to leadership. She spent an awful lot of time, the first part of the 2-year tour I was there, developing the effectiveness of our team. And she did that through a structured series of organizational effectiveness training sessions, and really developed the trust between the 3 deputy commanders and the commander and the command sergeant major in a huge way, in a way that I've tried to replicate every other organization I've been to since then. She remarkable leader, and I learned a great deal from her. So.
That's neat. What in particular have you tried to replicate or carry from those lessons? What did you take away from it, saying this is what I want to do in the future?
So most organizations you go to, you arrive into a team that's already established, and there's a certain amount of time that goes by where team members learn to trust each other and learn what motivates each other. And one thing that she did that I've tried to do is very early in that team forming, whether you're joining a team or whether you're the entire team is forming new, is you bring in outsiders, trained organizational effectiveness trainers who talk about the mission, who help you learn about each other, help you learn what motivates you personally, and you share that with the group. Yeah. And they do some personality indicator things, like I'm an extreme extrovert. I know what motivates me, but others may not know that. And so there's a series of exercises where you go through where you disclose this information, and it really leads to some very quick turns on team forming, storming, norming. You go through the normal team forming process in a very short period of time. One that would take, a normal 6 months period, you do that in a couple weeks. And so you get to a level of effectiveness much quicker.
Okay. So you think it is useful to take some time out to do that kind of these kind of exercises where you really do get to know each other? And
absolutely. And you form expectations of each other.
Okay.
Everyone knows up front these are our boundaries. This is how we're going to operate. This is how we're going to communicate with each other. We all are motivated by the organization achieving success. If the organization is successful, we personally will be successful.
So it's useful. Obviously, some of that can be encouraged or helped by outsiders,
yes.
You said, which is a useful thing. You think it is useful to bring somebody from the outside, even if, with your experience in having an MHA and having been a commander,
right.
It's still useful to bring somebody from the outside rather than saying, I can do this myself.
That's correct. Okay. And it's because sometimes you're too close to the situation. You can't see, you can't be objective about how the team is developing.
Okay. So from there, you went to down to here. You came down to Fort Sam Houston, where we are today, to Brooke Army Medical Center.
I did.
It was Brooke Army Medical Center at the time. I guess kind of still is.
Yes, it is.
But it was so Brooke at the time, or BAMC as we refer to it in the Army, and you were the DCA or Chief Operating Officer there. BAMC is the second largest Army hospital with over 5,000 employees, 35 teaching programs. It's got a burn center and a level 1 trauma center. And if that wasn't enough, you were also involved at the time, and when I say it's kind of still is, you at that time, the federal government had decided to make an investment to build, basically double the size of the facility, merge it with the Air Force in a way to create the San Antonio Military Medical Center, a $700 million project. And so talk about the hours that took from.
A piece of cake, right?
Yeah, it sounds like it.
Yeah, and this happened about 4 months after the Washington Post Walter Reed scandal. There was a lot of attention being paid to how our military treated our combat veterans. So we were standing up special organizations to take care of our recovering veterans. That was a very tough time for our military. And a very rewarding time for me personally at Brooke Army Medical Center.
Okay.
Now So now, 5 years later, it is, well, it's longer than that, gosh, 7 years later. So now it's the largest hospital in the Department of Defense.
Okay.
It's a 2.5 million square foot hospital, state-of-the-art, world-class everything. At the time, we were really doing things kind of one day at a time. Things were changing so rapidly.
Okay.
Developing relationships with our sister service, the Air Force down in San Antonio, that was a day-to-day process. The process of developing the requirements for our new facility that we're building here, and putting them on paper, and then doing the project management to do this huge capital improvement project. At the same time, we were standing up other organizations to take care of. It was just a very chaotic time.
And you were still running a very large hospital
and we were
at the same time.
Exactly right.
Yeah.
But when you felt like you were getting burned out and you were kind of at your rope's end, all you really had to do was go walk down to the burn unit or walk over to the Center for the Intrepid, which is a world-class rehabilitation facility for burn, amputation, amputee care, and limb salvage care, and talk to any of those soldiers who were incredibly grateful for the care that was being delivered. That really gave you a second win, and a third win, and a fourth win, and really kept you grounded in what the organization and what the Army was all about. I came into that job thinking, this is at, I think, about the 22nd year of service. I came into that job thinking, I am retiring after this, because at this point I was just very tired.
Yeah.
Because you're working very hard.
Yeah.
And that was one of the most professionally rewarding 3 years I've spent in the military. Really gave you a sense that we are incredibly patient focused, which is a theme we want to get to across all of Army medicine, and we really felt close to our mission and how we were delivering care to our patients. Really a remarkable time.
Okay.
Yeah.
So you did eventually get an opportunity to slow down for about 4 months. You got to be the Chief of Staff, Chief Operating Officer, if you will, for the AMED Center and School, kind of the home of Army medicine education.
Yes.
Except, like I said, you only got to do that for 4 months because the Chief Operating Officer position for the Army Medical Department, the whole Army Medical Department, went vacant, and you were tapped to step into that role. Kind of unexpectedly.
Very unexpected.
Okay. So you went from kind of overseeing education and so forth to actually kind of monitoring the functions of the entire medical department. A $13 billion budget, 3.9 million beneficiaries, 50 facilities around the world, including 8 academic hospitals, and, oh, by the way, still in charge of training all the medical assets for the Army. So what was that like?
That was overwhelming.
Was it?
That was incredibly overwhelming. And this happened, I got there, I took Mr. Herb Coley's job. Mr. Coley had been serving our nation for 42 years at that point, either as a commissioned officer or as a Department of the Army civilian, and a superb leader, and I knew that I wouldn't be able to replace Herb Coley.
Yeah.
I knew that the job as I worked it would be different than what he did.
Right.
I knew that because at the time when I took it, we were reading in the media about sequestration and budget cuts, and doing our mission with fewer resources. And then it became not just sequestration, but it became furlough of our Department of the Army employees, and a 40% decrement in our budget during that first year, and being able to continue to deliver high quality health care without a loss of quality. Yeah. And so in many instances, that very long 7 months that I did that job were really about dealing with the crisis of the hour or of the day.
Okay.
And at that point, I think I relied in a huge way on relationships that I had built over the last 20 plus years.
So you called on a network that you had been building.
I did.
Yeah.
And I really made great efforts to actively communicate with our 10 major subordinate commands throughout Army medicine. I believe we are a very, very large enterprise. And if we didn't make the effort to actively communicate, then there was going to be a lot of chaos throughout our ranks. And so I made a great effort to do that, to actively communicate through email, through phone, through face-to-face conversations.
And when you're working at this level, there's no more of just walking down the hall and shaking people's hands.
That's
right?
correct. Yeah, and there was a fair amount of that too, because even at the corporate headquarters, when you have 500 employees here at the corporate headquarters, that they're reading the same newspapers that American citizens are about our nation is reducing budgets and furloughs, and so there's a fair amount of walking around the headquarters and maintaining your morale and doing that thing too. But no, it wasn't like my early days when I did a lot of management by walking around and pulsing the morale and training and resource needs of our of my unit. I couldn't really do that effectively.
So a different kind of communication, though. You're saying communication was still central here. It's just a different kind of communication that you had to
That's correct.
really learn and put into place.
You have to be very upfront and transparent in times when times aren't going well. When things aren't going well, you really need to be communicate often and be as transparent as you possibly can with those you work with. They have to be able to trust you. Trust is hugely important. And if they don't, you're really going to have a tough time meeting your mission.
Okay. So you did 11 months in that position. Is that right? 11 months?
It was about 7.5 months, and then I was replaced by Mr. Fiore, and then I stepped down to be the deputy. For a couple months before I got my current position. Okay,
and so your current position is Chief of Staff of the Southern Regional Medical Command, or Chief Operating Officer for the Southern Regional Medical Command. Right. So tell me a little bit of what is the Southern Regional Medical Command? What does it do? What's its mission?
So the Southern Regional Medical Command is one of those 10 major subordinate commands of Army medicine that I just spoke about. Of the 10, there are 5 regional medical commands that provide health care. Our region is the southeast quadrant of the United States. So west almost all the way to El Paso, Texas, up to Arkansas, including Arkansas and Oklahoma, all the way out to the East Coast to include Puerto Rico is our region. We have 11 major hospitals or health clinics at installations across the southeast United States, and they have many subordinate clinics that are either within their facility or distributed throughout their geographic area. We have about 28,000 people we're responsible for.
They're employed by
They're employed by CERMC.
Or report to CERMC in some
That's
way.
correct.
Okay.
That's correct. And depending on what monies you count, we're about a $1.8 to $2.4 billion a year organization.
Okay. Wow.
Yeah.
That's a huge scope.
It is.
So, what do you do? What do you do as the COO?
As the
Chief of Staff?
So my title is Chief of Staff.
Okay.
So I coordinate all staff actions within the headquarters, and I serve as my boss's eyes and ears and her right hand man. Really, she leads the organization. I run the organization. If that makes sense.
Okay. Well, tell me a little bit. What does that mean on a day-to-day basis? who are you meeting with? Who are you talking to do the running of the organization?
So out in our out in the region, there are 11 different medical treatment facilities,
okay.
hospitals, major medical centers, and each of those medical treatment facilities has a CEO, a subordinate CEO.
Okay.
So my role really is to provide those leaders with the resources they need to be successful.
Okay.
To make sure that they're delivering the health care that they've contracted to deliver. Okay, so holding them accountable. In some cases, going to our higher headquarters asking for more resources. And in many cases, serving as a buffer of information between our higher headquarters and that organization.
Okay.
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 I know that's that's overly simplistic, but that's really what I do.
So who else is here in the C-suite, if you will, that you coordinate with?
So our governance structure.
Yeah, that's
we've got our commanding general.
Uh-huh.
In our case, is a 2-star billet.
Okay.
And then I'm the chief of staff, and then subordinate to me we have about 8 other assistant chiefs of staff for logistics and personnel and clinical operations and quality. And I also am in charge of a number of special staff officers.
Okay.
We have a chaplain. We have a public affairs officer.
Yeah.
We have an inspector general office that does investigations and serves as our commander's eyes and ears out in the organization.
Okay.
So I basically, yeah. Go
Okay.
ahead, Mark.
So I was so do the hospitals report, or the subordinate organizations report? The commanders of those organizations report to you, report to the general. How does that work?
So routinely, I'm talking to those commanders on a daily basis.
So that's where you're talking about you're running the organization. You're
Right.
probably filtering the information.
Right.
Okay.
That's correct.
What's the role of the commanding general then, as leader, as you said?
So our leader, our general, she gives us strategic direction.
Okay.
She gives us our priorities.
Uh-huh.
She represents us to our higher headquarters and to the community, and to our Army stakeholders. She's involved in the up and out communication and coordination, and I am much more focused on the down and in coordination.
Okay. So what on any given day might draw your attention to a particular facility in the region?
Any number of things. We are very focused on delivering high-quality, patient-centered care in our enterprise, across our enterprise, and we're doing it every year with fewer and fewer resources. So our higher headquarters expects us to be accountable for the delivery of healthcare, and so every week we focus on a specific service line. For example, this week we're focusing on the delivery of inpatient care, and whether our staffing levels are, whether we're overstaffed in certain areas, understaffed, whether we're providing the average daily patient load that we should be doing, whether we're achieving the patient satisfaction scores we should be in each of those areas. Sometimes it's a so that's the big picture. The small picture may be we receive a congressional inquiry from a member of Congress who's very concerned. They've gotten a letter or a phone call from a constituent who's concerned about a treatment of a soldier or a patient in one of our facilities, and we have to investigate and provide a response to that constituent. And so it's any number of things like that.
So it's very much from the macro to the micro.
Absolutely.
You're covering the range of things.
That's correct.
Well, so what keeps you up at night as the chief of staff of CERMC? What do you worry about these days in particular? Anything?
I worry about the our ability to provide, and people say world-class care, right? I worry about our ability to deliver world-class care in an environment where that is becoming increasingly critical of our effort. I see the great work Army medicine has done over the last 13 years, incredible work, that the public may or may not appreciate because the public's been largely insulated, I guess is a better word, from the great care that's being delivered. And I worry that that our current structure will be degraded in some way because of that insulation. Because the public doesn't know that what's going on, and I really don't know how to, our value system, our ethic is not to be self-promoting in the Army, right? And so I think that works against us in many ways, that in that the public doesn't understand what we've done, and Congress is holding us accountable for the delivery of health care and the resources we spend. And so that does keep me up at night, worrying about what the future will bring.
All right, so let's close on some thoughts about leadership and mentorship. What kind of mentoring relationships are you involved with today or now, and how many of them come from kind of your position as chief of staff? So formal relationships. So, for example, I was waiting to meet with you. You were having a counseling session with one of your current reports, but do you have, so that's kind of formal arrangements, but do you have informal mentors, mentees, I should say, that kind of come to you for advice?
Over the past 3 years, I've been the consultant to the Surgeon General for Healthcare Administration. So that's a formal role. And as in that role, I've really led the career development and leader development of all healthcare administrators in the Army. And my location here in San Antonio is pretty important and pretty integral to that, because I'm located geographically on the same installation where all of our leadership training is done for our officers. So on a typical week, I will get mentorship requests, either an office call request, an email, a phone call, from anywhere from 3 to 10 officers every week. And I always make an effort to set aside time. When you get an email at 9 o'clock in the morning, you may not have the time right then to talk with that officer, but you always set up time later in the day or later in the week to sit down with that officer and talk with them about their career and what the future holds for them. And I've really taken great pride in doing that over the last 3 years or so. I've been doing it all my military career, but this formal role I've been in has really been very rewarding for me personally. I'm going to leave the Army. The Army will keep rolling along, with or without Bitterman, right?
I've noticed it's still functioning without Bonica.
It's still functioning without Bonica, and it'll still function without Bitterman. But you know what? The things that you do as a leader, either in a way that is that everyone acknowledges, or just the things you do that are observed by other leaders, they really form the kind of the leadership recipe that makes somebody else a good leader. And so the more time you can devote to more junior leaders, and developing their skill set and the way they think and act,
Yeah.
I think pays huge dividends for the enterprise down the road.
So you talked a little bit about how you drew on your network.
Yes.
Especially when you went into the position at MedCom as the chief of staff for the entire medical department. Can you talk a little bit about the importance of cultivating a professional network, and how have you done that in your career, and kind of how have you done that, I guess I should say?
Well, you do it within your organization, and within, in this sense, the organization I'm talking about is the United States Army, not necessarily the geographic location you're in.
Uh-huh.
You do that through reputation.
Okay.
You do that through word of mouth, by picking up the phone and calling people, talking to people. You also do it between. I've done a lot of community outreach, right?
Okay.
And so the vehicle I've used is my professional organization. I belong to the American College of Healthcare Executives. I'm a fellow in the college. I've been a fellow for a while. I've been in the organization for 20 years now. And like any other profession, healthcare administrators need constant leader development and progression to be effective. And so that's what I've used as my vehicle. It doesn't matter whether it's American College of Healthcare Executives or one of the other great professional organizations we have out there. You really need, as a leader, no matter how old you are or how long you've been doing this work, you need to continue to learn and get better and foster relationships with others and help when someone calls asking for assistance, either a technique or even actual physical resources, or someone to talk to or talk to a group. You do what you can at that time, because it'll pay dividends down the road. Did I answer your question?
Yeah, absolutely. That's great. So what advice would you give to someone who's thinking of making a decision to become a healthcare leader, to take on either a person like yourself who, a young person deciding, I want to get into healthcare administration, perhaps a clinician who's looking to make a transition into a leadership role from a clinical role? What would you say to them about the field, and what should they do to try to, decide, is this their calling, and and what should they do to try to figure that out?
That's a great question. I would tell you that first off, you need to do some self-assessment on why you want to enter this career field. Much like my decision early in my career not to pursue medical school, you need to do it for the right reasons. You truly are. I think the best healthcare administrators are really those that are cut from the servant leader model.
Okay.
You are of service to your community, whatever community you belong to, and if you can do a self-assessment of your motivation and your goals, and realize that really the reason you're doing this is to be of service, I think you're doing it for the right reason.
Okay. And if it's the right reason, then it should
Right.
make you pretty happy.
Right.
Yeah.
And I tell young leaders this all the time. If you don't love your work,
Yeah.
you need to find a new occupation, because those who work for you know you don't love your work.
Yeah.
So
earlier at the beginning of the podcast, you mentioned your life goal. So why don't we see? Maybe we'll close on that thought. So, what is your life goal, and how does that fit into what we've been talking about?
Yeah. So back in '91, when I did my career map with David Rubenstein, my career map went out to year 30.
Okay.
In military service.
Okay.
That's where I'm at right now.
It is, right.
And what have I done with my career map, and what's my goal? I see myself, my role, I'd love to find a role after I leave the military where I can continue to influence young developing leaders.
Okay.
I think that is hugely important for the Army, for Army medicine, and so that I think that's my life goal, to continue to be of service. I really I think that's important, you know.
That's a very respectable life goal.
Yeah.
So you did say 30 years is coming up.
Yep.
Mandatory retirement.
Mandatory retirement.
So any specific plans yet, or is that still too soon to say?
I have, you know, we've talked about balance too, right?
Right.
You know, I have one goal when I leave the Army. I am going to ride my bicycle down the west coast of our nation, start in Vancouver, Canada, and end in Mexico.
That's excellent.
Take about a month to do that, and do a lot of thinking and reconnecting with America during that time. And then I'll come back here to San Antonio and I'll figure it out. I'm not being coy. I really, a lot of people have been talking to me about, you know, hey, I've got this position, Dave. Are you interested in doing this? And every one of them I've told, that sounds very exciting, and I'll be available after the 1st of August, and I'll worry about it then.
Yeah.
I really need to. I think everybody needs to take time out in their life to figure out what's next, and how can I make the greatest impact in the very limited time we have left here on Earth, right?
Yeah.
And so that's what I'm going to do. Take some time and do that.
That sounds great.
Yeah.
Thank you so much for talking with me today. It's been a pleasure to see you again.
It's always great to see you, Mark.
Thank you. You've been listening to the Health Leader Forge, a production of the College of Health and Human Services at the University of New Hampshire. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll see you again in about 2 weeks.